Hey everybody! Today we are going to be talking about celiac disease, and this is something that is very close to me because it's an illness that runs in my family. So when I was given the opportunity to research it more for a class, I decided to do that, and it's been very interesting for me to get to know more about the scientific side of the illness and how the body reacts at a very in-depth level with people who have this illness. And so today we are going to be talking about what celiac disease is, what the symptoms are of it, who is at a higher risk of developing celiac disease, and the genetics behind it. And then also just the symptoms, the testing methods, the treatment methods that go behind a diagnosis. And then after we go in depth about what the illness is, we will look at two different cases of people that were diagnosed with celiac and compare those cases and see how they differed in the symptoms and the testing and the treatment methods. And then finally, we will look at what the current research is in developing new methods for treating celiac disease. Celiac disease is a hereditary hypersensitivity disorder that causes somebody to be sensitive to ingesting gluten. And what this means is that when somebody with celiac disease eats gluten, their body thinks that it's a pathogen and starts this inflammatory immune response to get this pathogen out of the body. However, in response to the gluten, the small intestine is also damaged, and that causes the patient to be unable to absorb nutrients efficiently. Gluten is a family of proteins that are found in the grains wheat, barley, and rye. And the main two culprits that celiac disease patients have an issue with are glutenin and gliadin. And these two proteins are what causes bread dough to rise and have elasticity. It gives bread the texture that you think of when you think of bread. And there are a few different illnesses that are sometimes grouped under the celiac disease umbrella, and so we're just going to differentiate those real quick. So celiac disease, as I have said, is defined by having a reaction to gluten and that reaction causing the intestine to become damaged. And symptoms that go along with classical celiac disease would all be GI symptoms like bloating and diarrhea. Whereas we have a wheat allergy that the patient will react to a protein in the wheat, not the gluten protein, it is another protein. So wheat allergy patients are capable of eating barley and rye without any problems. Generally, the reaction to wheat in a wheat allergy would be an anaphylactic reaction. So that differentiates it from the GI symptoms of celiac disease. And also with a wheat allergy, you aren't having the damage to the intestine. That is only with a celiac disease gluten allergy. And then the third illness that will differentiate would be non-celiac gluten sensitivity. And this is a pretty new diagnosis, so not everything around it is fully defined. But we do know with the patients that have non-celiac gluten sensitivity, they are unable to eat gluten without some sort of reaction. Generally, it's not as severe of a reaction, but they do have some sort of indigestion when they ingest gluten. In Europe and the United States, 1 to 2% of the population has celiac disease. And while this may not seem like a very high percentage, it's only 1%, when we're talking about autoimmune disorders, 1% of the population having one specific autoimmune disorder is a high percentage. The highest percentage in the world is in the Western Sahara Desert, and 6% of the population there has celiac disease. Now, if you have a family member that has been diagnosed with celiac disease, you have a higher risk of developing it because it is a genetic disorder, so it runs in your family. First degree family members of a diagnosed celiac patient have a 10% risk of also being diagnosed themselves. And while celiac is a very well-known autoimmune disorder, probably the most well-researched autoimmune disorder there is and most well understood, it's still pretty highly misdiagnosed because of the symptoms. It is estimated that for every one diagnosis of celiac disease, there are about 7 to 10 patients who have not been diagnosed or have been misdiagnosed. I've mentioned that celiac disease is hard to diagnose, and that is because the symptoms differ depending on the age of the patient at diagnosis. So we're going to talk about the 5 different types of celiac disease and how those symptoms vary. In classical celiac disease, that will generally be a patient under the age of 2 years old, and they will have solely gastrointestinal symptoms. It'll be bloating and vomiting, diarrhea, malnutrition. And that's probably the easiest type of celiac disease to diagnose. And then, still in the realm of classical celiac disease, we have children that are older than 2 years old. Still probably have a lot of gastrointestinal symptoms, but they start to have other symptoms too, like headache and puberty delay and growth delay. When we start getting into older children and adults, that will be grouped under atypical celiac disease, and in a lot of those patients, almost all of the symptoms are not gastrointestinal. They are osteoporosis or arthritis or anemia. Some have elevated liver enzymes or skin lesions. And this atypical celiac disease just makes it a little bit harder to diagnose. So asymptomatic celiac disease patients don't have any symptoms at all, but when they have the serological and histological tests done, they come back abnormal. So damage to the gut is being done, they just don't have the symptoms of it. A different type of celiac disease that lacks symptoms is latent celiac disease. And latent celiac disease would be a patient who tests abnormally in a blood test, but the intestine has not been damaged. And so this is the only type of celiac disease patient that does not need to go on a gluten-free diet. The only way that this patient would need to go on a gluten-free diet is if they start to have intestinal damage. So the 5th and last type of celiac disease would be refractory celiac disease, and that is a patient who has been diagnosed and has gone on a gluten-free diet for a significant period of time, and they're still having symptoms. Their intestines have not healed. And this occurs in about 5% of the patients diagnosed. And it isn't very well understood why they don't heal. It's just known that they continue to have issues even though they have gone on the gluten-free diet. And some of those patients will initially start healing and start doing better on the gluten-free diet, and then they'll just kind of slide back down into the bad place that they were before diagnosis. Gluten is a proline-rich protein that is not able to be completely broken down by the human body. And this is the case with everybody. Nobody can fully break down this protein, which means that larger molecules than normal get to the small intestine. And this is not a problem in most people. The only people that it's a problem in are those that have the genes associated with celiac disease. So when this gluten gets into the small intestine, it's a larger molecule than normal, and it is capable of breaking down the tight junctions between the cells in the lining of the small intestine. And once it breaks those down, it's able to enter into a layer that normally such a large molecule would not be able to enter into. And once this happens, the genes that are associated with celiac disease have really good receptors for gluten that just fits gluten very perfectly. And so these receptors will bind to the gluten and present it to CD4 T cells as a pathogen. And when the gluten is presented to the CD4 T cells, that starts the inflammatory response. And the issue is that If the person continues to eat gluten and they have these genes that will present gluten as a pathogen to CD4 T cells, then this inflammatory response is going to continue on, and it will turn into an issue of chronic inflammation, which is very damaging to the body. The genes that are associated with celiac disease are called human leukocyte antigens, or HLA genes. And the two specifically that code for celiac disease are HLA-DQ2 and HLA-DQ8. Now, you can have one of these or you can have both of these. You can have 2 copies of one of them, but just because you have the genes doesn't mean you have celiac disease. The most common gene associated with celiac disease is the HLA-DQ2 gene, and 90% of patients diagnosed with celiac disease have this gene, whereas the other 10% have at least one copy of the DQ8 gene. You have to have at least one copy of one of these genes in order to have celiac disease. Now, the reason that some autoimmune and genetic disorders are also associated with celiac disease, so you have a higher likelihood, say if you have type 1 diabetes, you have a higher likelihood of being diagnosed with celiac disease because the same genes code for celiac disease as do type 1 diabetes. There are 2 tests that are considered to be the gold standard for celiac disease testing, and that's the IgA anti-tissue transglutaminase antibody test, or TTGA, and that is an enzyme-linked immunosorbent assay. And then just having a GI biopsy done would be the second one. So TTGA tests will test for those antibodies, and that is a 98% accuracy test. And another test that is also sometimes run with the TTGA would be an IgA anti-endomysial antibody test, and that one has slightly less accuracy but a higher specificity, so generally those two will be run together. And then also, if the IgA testing comes back positive, then to confirm the celiac disease diagnosis, a gastrointestinal biopsy will be done. And the biopsy just confirms that there is intestinal damage. So for celiac disease, they will rate that on what is called the Marsh scale, and it goes from 0 to 3C, and anything testing in the 3 category, so 3A, 3B, 3C, any of those are positive for celiac disease. And that just is telling you the amount of damage done to the intestines. There's a couple other tests that may also be run. A stool test may be run, and that is the patient will give a stool sample and it will be tested for fat content, because damage to the intestine through celiac disease could cause excess fat to be excreted in the fecal matter. And there was at one time testing done for IgA or IgG antibodies in stool samples, but that has been found to be pretty unreliable because healthy people have IgA and IgG antibodies in their stool sometimes. An iron deficiency test may also be run through a blood sample, and that is just because anemia is common in celiac disease patients. Completely eliminating gluten from your diet if you've been diagnosed with celiac disease is currently the only treatment method for celiac. And this works in almost everybody except for, like we discussed before, in refractory celiac disease, where the patient eliminates gluten from their diet for an extended period of time, generally 6 months to 12 months, and still remains to have intestinal damage and symptoms. It is suggested that if you suspect that you have celiac disease, whether it's because of a family history or your symptoms or anything, if that is a suspicion, you go to your doctor first and have the testing done, because the longer that you are off of gluten, the more likely that your testing will be negative. After a year, most people have complete healing of their gut, and so their biopsy, their blood tests, their stool tests, everything will come back negative for celiac disease, because you have to be eating gluten in order to test positive with the current testing methods for celiac disease. Now we're going to review a couple of case studies. One is of a 12-month-old female who was diagnosed with celiac disease, and the other is of a 20-year-old female. So we'll start with the 12-month-old female. Her parents brought her into the doctor because it just seemed like she had a loss of appetite and just wasn't as energetic as she had been. So they continued to observe her for 3 months under the care of this doctor, and at the end of this 3-month period, she had lost weight, she was pretty lethargic, she had bloating, she had significant foul-smelling stool, and she was very weak. This patient, the 12-month-old, had no family history of any related illnesses to celiac disease or celiac disease itself. Tests were run at this point, and she had a reduced hemoglobin level and elevated liver enzymes. She tested positive for anti-endomysial IgA antibodies and also anti-gliadin IgA and IgG antibodies. At this point, because of the way her test came back, she had a GI biopsy done, which confirmed a diagnosis of celiac disease because of her symptoms that worsened over the course of a few months because of her blood tests, and then now after the biopsy because of her histological testing. The next case study that we will look at is the 20-year-old female, and this woman was a collegiate athlete, so she was very active, very healthy. She didn't have GI symptoms before going to college. She presented in college with chronic back pain, which was treated through her trainer at school and through a sports doctor, who they did massages and stretches and strength training and electrostimulation. These treatments for the back pain helped relieve her pain, but they did not take it away completely. She had a history of severe eczema, of mononucleosis, arthralgia, myalgia, chronic diarrhea, and fatigue. Her eczema and mono had been in the past before she got to college, and then once she got to college, she started having more of the GI symptoms. Her back started hurting, she started having diarrhea and fatigue, and she was sent to an allergist who ran antibody tests and was found to have an allergy to gluten, spelt, barley, lactose, albumin, and rye. This allergy testing suggested that she does have celiac disease. She also had diabetes and lupus testing, which both came back negative. She continued to have the muscle pain. It was treated, like I said, with the stretching and strength training, and just didn't completely take away her pain. Her mother at the same time was having similar GI symptoms, thinking that it was potentially linked to gluten or wheat. A biopsy was never ordered for this patient because one of her doctors didn't think that celiac disease was a legitimate diagnosis for her due to her symptoms, so her insurance wouldn't cover the biopsy. However, she and her mother both decided to go on a wheat-free diet, not a gluten-free diet, but a wheat-free diet, to see if that helped with their symptoms. Once the patient went on a wheat-free diet, she felt like her symptoms were reduced, but not completely eliminated. This suggests that she does indeed have celiac disease. However, she was not officially diagnosed with celiac disease because the biopsy was never run. There are various different forms of research going on right now to help with the symptoms of celiac disease. Some are looking for a cure, and some are just there to help with the symptoms. One company, Imucin T, is developing a vaccination called NextVax2, and this is hoping to be a cure for celiac disease someday in the near future, but it only treats those with the DQ2 gene. And it is similar to an allergy shot where it will be a series of injections that will retrain the immune system to not see gluten as a pathogen and not induce that inflammatory response when gluten is ingested. Another company that is trying to help with celiac research is Immunogen X, and that is in cooperation with the Mayo Clinic, Their trials are called CIPCEL, and they are testing a statin drug to see if that is a better testing method instead of biopsies to diagnose celiac disease. So the thought behind this is the statin will be given to the patient, and then blood will be taken at certain intervals of time, multiple intervals of time, in order to see how the statin is broken down. And this is because in a healthy patient, statins are broken down in the gut, and they are broken down relatively quickly. However, if your intestines are damaged, the statins will be broken down more slowly, and you can see that by the amount that are floating around in your blood after a period of time. The last trial that is being conducted right now that I'm going to talk about is called Z1227. This is a transglutaminase inhibitor, and the reason for this is that one of the things that happens in a patient with celiac disease when they ingest gluten is that once the proline residues get to their intestine, they react with transglutaminase. And this is a problem because this is what starts the inflammatory reaction. This specific drug will block transglutaminase 2 mediated deamination of gliadin peptides. The hope for this medication is that they will one day be able to find a dose that a person with celiac disease can take before they eat or in congruence with while they are eating gluten, so that their body won't react anymore or will be inhibited from reacting. In conclusion, today we learned that only people with the HLA, DQ2, and DQ8 genes can have celiac disease, and these genes are what present gluten to the T cells in your immune system and start that inflammatory process. This inflammatory process is bad because it turns into chronic inflammation if you continue to eat gluten, and that destroys the small intestine, and this can cause malabsorption. The testing methods for celiac disease will be to test for the TTGA test, testing for IgA antibodies, and also a gastrointestinal biopsy, which tests for damage to the small intestine. Gluten is the problem in celiac disease. It is a family of proteins that are found in the grains wheat, barley, and rye, and the two proteins in that family that give the most issue for celiac disease patients are glutenin and gliadin. This is because they are proline rich and they do not get completely broken down before they reach the small intestine, and if you have the genes that are associated with celiac disease, they have receptors that are perfect to grasp onto gluten and present it to T cells like it's a bad thing to have in the body, even though it's not actually a bad thing to have in your body. So as we've learned today, anybody can be diagnosed with celiac disease. They just have to possess the correct genes. Just because you possess the genes that cause celiac disease does not mean that you have it or that you will ever have it. Something has to turn these genes on. Thank you for joining me today. That is all I have for this presentation on celiac disease. If you would like to learn anything more, I will have my sources linked in the description below, and you can read some journal articles, and read even more than I was able to present today.